taking its time. Okay, so hi everybody and welcome to another video. I'm Diane Danzibrink, founder of Menopause Support and the Make Menopause Matter campaign. And I am delighted that the lovely Dr Anand Patel has agreed to chat to me this evening because some of you may have seen Anand on the programme called Gone Fishing with Mortimer and Whitehouse. And there was a lovely section in that programme which was all about men's health. And so I went onto Twitter, found the lovely Dr. Patel, messaged him, and after a few weeks and a house move for him, here we are. So Anand, a really warm welcome and thank you so much for your time.
No, thank you, Diane. Thanks for sending a message on Twitter, which I try and avoid to try and keep my brain sane. But no, it's lovely to be here finally now that I've moved and we've managed to get time together.
And you're settling in nicely to your new home?
Perfect. The reason that we're filming from up here is the boxes under there, so that's where we're going to keep it for now.
Brilliant. So Anand, for people who haven't come across you before, would you be kind enough just to tell us a little bit about yourself?
Sure. So I'm a GP, just a generalist working in Stockwell in London. That's part of what I do, and I absolutely love it. Trying to organise both the sort of practice side of things, like the newest thing now is the COVID vaccination, which we're going to be aiming for, and trying to do from our practice actually, which is a big thing.
Wow.
And then the other side of stuff is the sexual function stuff, which I get to do on Mondays at the Centre for Men's Health. So it's a brilliant opportunity for me to kind of do the bits that I love and also keep up with just the really exciting bits of sort of men's health and sexual function that I get to do, which comes up a lot in general practice, but you've got 10 minutes, and having the chance to have 60 minutes with someone is incredible in terms of getting a much deeper conversation about what they think the issue is and what the problem is, and then trying to unearth some of those things behind it, because it's obviously not just their physical function, it's about what's happening at home, what's happening at work, what does it mean to them that their erection isn't working, why have they got so worried about what they think is the andropause or whatever it is that they think is going on, their testosterone's not as it should be, or they're not as sexually interested in their partner as they perhaps were 30 years ago. And it's nice to sort of kind of just, you basically just sort of lay sort of worries to bed. You just I'm mixing my metaphors. You put worries to bed. You don't, most of the time it's just about letting people know what's normal. We get loads of men, for example, with issues with premature ejaculation or delayed ejaculation. It's just about saying, well, actually, how long do you think that you're going for? Like, oh yeah, but I want to be going for half an hour. And you're like, oh, no wonder you're losing your erection. Your other half must be getting exhausted or pressure sores or something, some sort of rug burn. But yeah, the average in the UK, the Durex did a study, and it was 5.4 minutes from penetration to ejaculation. So if you tell people that, they're like, oh, so I'm not premature ejaculation. No, that's actually, you're doing twice as long as normal, and perhaps you're losing it because you're so focused on your erection, you're not actually thinking about just enjoying yourself or just seeing what your partner's doing in response to whatever you're trying to do.
It's really interesting. It's so interesting, isn't it? How so much of kind of what we think is based on perception or expectation. And sometimes that's expectation that we put on ourselves, not that other people put on us.
I mean, a lot of the time, we have had the influence of porn, which has been much more out there since higher speed internet access has arrived. You've got people who they curate almost a series of videos that they masturbate to, and often they're not using lubrication, so they get what's called death grip, where you've got men squeezing their penis so hard that actually they increase the threshold at which you can achieve sort of orgasm and ejaculation. So when you then try and have sex with a mouth or an anus or a vagina, you find that actually nothing squeezes as hard as your grasping hand. So it's about trying to educate people, going, look, maybe that's not the best thing for you to be doing. And I'm certainly not saying all porn is bad at all. I mean, there are some people who actually, it's an educational tool more than anything else. It's so difficult for some people to talk about sex, some cultures to discuss sex openly. Unfortunately, in the UK, our sex education still isn't up to supporting young people in terms of what they really need to know, which is not just the mechanics of sex, although some of that is still not talked about. I mean, we were talking just a bit earlier about me being the head of PSHE when I was a school teacher a while ago, and I mean, there's me trying to put, shall I put anal sex in a lesson plan? You're kind of like, okay, no. And partly this was 17 years ago, but also it just feels a bit uncomfortable sometimes, a man discussing anal sex with a mixed class. But also it shouldn't be like that. 35% of 16 to 25-year-olds are gonna try to have anal sex or partake in anal sex. And so you're like, well, I'm just not going to give them the tools to talk about it, or to work out, actually, they might want to think about some lubricant or stuff. We do have the occasional injury that goes into A&E because, people were messing around, and, the guy, whoever, didn't know to use lube, and they just pushed in, and it was unfortunately very painful, even traumatic.
Yeah, absolutely. So one of the things that I was really interested to know, because obviously there's never enough time in a TV program to hear what you really want to hear, and I was very much kind of left going, oh really, like, can we not hear more about this? Is that obviously it's the last day of Men's Mental Health Awareness Month in November. And I was just really interested to know, both as a GP and in your other practice, what are the most common things that men will come and talk to you about? Because certainly, sort of talking to a lot of other women, they will say that they find it very difficult to get their husbands or their partners, and it is generally their husbands or their partners, they're not generally talking to other male friends about these things, but to actually get them to go along in the first place and talk to a doctor. So I wondered what the most common issues that present with men in either practice are.
So, I mean, in general practice, a third of our consultations are probably mental health related. And more commonly, you will get women presenting earlier and younger, because actually they will perhaps recognise that there's a problem, talk to their friends about it more openly in general, and then come and see their GP. So they often do that early on in the process. So within a few weeks or months of feeling low, and it's not everyone. There are still people who find that there's a lot of stigma attached to mental health and mental illness. So anxiety, depression, and people don't want it to be on their record. They don't want it to be on their insurance, or there's lots of reasons why you might want to not admit to that, or you have a family member who's been very unwell with anxiety and depression, and you fear that you're going to become that person. And so there's lots of issues why people don't come, but men particularly tend to present later, and often when they're in significantly more trouble. Right. So either they've got higher levels, more significant levels of anxiety, and either something's happened at work or at school or something like that, and they've hit a point where they're actually now sort of stuck in their bed, or they're stuck in their home, or work sent them away. Something like that has happened, or they've had a shouting incident at work, which is understandably work or school have said is unacceptable, and they've had to come to us in extremis. Alternatively, they're sent in by their partner, so we're very grateful for partners pointing out this is an issue, please could you go and get this sorted. And we, as busy as general practice is, we are open, we are entirely open, and we have been throughout COVID, and we would welcome anyone who's got any mental health concerns contacting us. I mean, unfortunately, the past 2 weeks have been dreadful in terms of the severity of mental health issues that we've been having. Just the number of patients who have actively been, either suicidal thoughts or even plans. We've got to the sense where we've got people's mothers ringing in on their behalf, going, look, I need to talk to you about my son, I need to talk to you about X. Look, I don't want you to tell them that I've rung in because they'll be furious. And you're kind of like, I'm like, I can't not tell them. If I ring that son up, or that husband up, or that wife up, or whatever, it's a bit sneaky if I kind of go, oh, I was just ringing. I mean, your doctor generally does not just ring. So it seems a bit sort of disingenuous to pretend that, but most are quite understanding. If a person comes into the room and they go, I was sent here by my mum, I'll be entirely understanding of that. I recognise why a young man would not necessarily, or any man would not want to come and speak to me about something they may consider an issue with their masculinity or their failing as a man. You know, men are meant to get on with things. I mean, I know women are, and they just do everything in silence, and they're meant to just put up with childbirth and everything else. You know, looking after a home and going to work simultaneously. But you know, men are taught not to express their emotions, and that expressing your emotions is a sign of weakness and failure. And therefore, if we are teaching young men this, and I think we've clearly been doing this for years, we have such a sort of powder keg of sort of repressed emotion or sort of unhelpful beliefs about health that then build up, that actually when something does happen, it does seem quite explosive or quite serious. And you know, we've got to recognise that 2/3 of all suicides are men.
I know. Yeah, absolutely.
It's a horrendous statistic. And as you get older, particularly, the proportion increases to 3/4. And as I'm sure you know, I mean,
40 to 49, isn't it? The greatest. Is that still correct?
Yeah, absolutely right. Absolutely right. And so it's so sad that that's the case, but also, and it may have been also that these people have reached out for help. And either it's not been forthcoming quickly enough, or the events around them have been so significant that actually the only way out they feel is to end their lives. So what we want to do is to try and sort of intervene or talk to someone as soon as possible. And it's not necessarily about us trying to find the right words that solve every patient's problems.
No, of course
it's
not.
about kind of just recognizing that absolutely they're in pain, and that we should take this really seriously, and that they're not a sort of bad or abnormal or person or a failure in themselves. They're not letting men down or letting their partner down or whoever down. People are often so frustrated about what work might say or what their mates might say, or what and men particularly, their world sort of concertina into themselves. You start off, you might have at school a wide range of friends. At university, it might be very wide, but as you get older and older, it tends to become your work colleagues, and then it's the school gates, and maybe those people you interact with, and it still gets narrower and narrower. Your children leave home, and actually after that, when you retire, I mean, retirement apparently it's in the top 10 of most stressful things that a man can do. So if that's the case, then we are setting up men, and as they get older men, to not be able to understand their changing emotional landscape, not be able to react appropriately to the way that others behave around them, not be able to change, for example, when jobs are scarce, money is so tight. They're worried about COVID, they're worried about Donald Trump, or whatever it is that they're worried about. And the fact we're all so connected must make the world so exhaustingly small. If we're designed to just know the people in our village, but actually our village is the same here as it might be, for example, in France or Germany or Rwanda or the United States or wherever. It's incredibly challenging for our brains to be able to manage that much information simultaneously. And I personally make sure I have times and periods of a few months where I won't read the news at all, just because actually I get enough sort of I think I've got to do enough risk management in my job, and the anxiety that actually you don't want to make a mistake, you want to make sure you do things correctly. So I kind of think, well, if that's actually enough for me, that's enough anxiety I'm going to take on. I can't quite look at the American elections. I can't quite look, I feel bad, I can't quite look at the number of people who are being pushed into poverty. I can't necessarily look at austerity and what the damage it's doing all the time, because actually my brain just can't comprehend all of that, and also try and support depressed people at work, people who've lost their jobs, the housing issues. Because like you, I'm sure we don't just get people who've got sort of physical health issues or mental health issues purely out of their own endogenous environment. They're a result of something. They're a result of poverty or deprivation or something like that. And I work in Lambeth, which is, I think, has the distinction of being either first or second in deprivation, and sort of in the top 10 for mental health issues. So you're like, well, it's a perfect storm.
Yeah, absolutely. So, Anand, when men do come along to you to, kind of talk about whatever the health issue is, sort of how do they tend to kind of present? Do you find that they are, I mean, it's like you can't talk about all men as doing the same, you can't talk about all women, but generally, do you find that they're looking for you to lead the conversation, Or are they, you know, kind of, do some of them come along and are more confident about how they share this information, whether it's physical, whether it's psychological, etc.? You know, what's your sort of, as you're sitting on the other side of the desk, what's
I mean, there seems to be two main groups. There's the sheepish group, who aren't really certain and are trying to sort of sound you out a little bit. And so either they'll kind of admit it in a slightly embarrassed way, or say someone sent them in or something like that. Or they'll tell you about their toenail, and actually as they get to the door, it'll be, by the way, and you're like, no, we've just spent 10 minutes on your toenail. I'd have liked to know about your depression earlier on. But I get, you know, you don't know me from Adam. How on earth would you know that I would be helpful to talk to you? And there's the second group that just sit down and go, right, I'm depressed, or right, I've got erectile problems, or right, I've got heart disease. You know, they come straight to the point with what the problem is. Because I think a greater proportion of people are used to now looking up their symptoms online. They're used to, you know, getting a bit more knowledge about themselves before they come and see me. And so sometimes I've brought bits of paper. I read something on the internet, or I saw something on TV. I mean, certainly when anything, you know, unfortunately when Jade Goody died of cervical cancer, that had such a big stimulus in terms of women coming to us, you know, searching for more cervical care. And you're thinking, yeah, I mean, that was awful, and particularly for her family, but also actually an incredible thing to share that publicly, which actually hugely improved sort of public health standing.
Absolutely.
And so you know, there's a whole number of things that trigger people to come in. But yeah, it's two groups. Either they're very certain and very clear about, look, I think I have this, let's sort it out. And it's very much about sorting it out. They're quite linear. And there's not so much of the sense that perhaps things might take time, perhaps there are other things around it that might need work. Ideally, they'd like something to be fixed and there to be a tablet that sorts it out immediately.
Very focused.
Very focused, yeah, very A to B, quite sort of, you know, Germanic in that sense. There's less of the sense that they would have to necessarily do the work that actually often comes with healing yourself. I don't mean that to sound all sort of you know, airy about it.
No,
but actually there is a lot of stuff that you need to do that doesn't just involve your body, to get yourself in a much better place. And you know, and discussing that with them is sometimes it's taken very well, and other times, like, you know, like anyone, it varies. Other times it's like, no, I just want tablets. I don't want to talk to anyone, and I want to go home. And you're like, okay, but that's fine, but we'll follow you up in 4 weeks and then see where we are. Not that I don't believe that they can do it or anything, or it's the failing on their part if they can't, but actually I've seen enough people kind of go, I wish I'd done this earlier. I wish I'd talked to someone about it and kind of worked out in my head what I'm actually thinking.
So, Anand, if somebody's watching this now, whether it is, you know, sort of whether a concerned wife or partner has kind of stuck this under her partner's nose, or whether a concerned husband or partner has stuck it under his partner or husband's nose. If that person, that individual that is being encouraged to go and see their doctor, is having to be encouraged, then, and they do make that appointment for whatever they're wanting to talk about, if they're, you know, not reluctant to go, but just don't know how to open the conversation, because maybe they just don't go to the doctor very often, what's your advice as the person receiving that information? What would you say to somebody, you know, about opening up the conversation to help the doctor to help you?
I mean, if you can, and you're happy to, come with the partner or whoever, because you often get some really good, helpful conversation on the side from that person. And often, actually, it's easier for them to start the conversation with what they first noticed. And so, you know, if people come in and they're a bit sort of quiet, or they're not sort of very certain about what's going on, I'd much rather they just told me what their symptoms were. So not the diagnosis, not what they think they have. Because I get a lot of, oh, I'm having a heart attack, and you're like, oh, but the way you describe it actually looks like it's your shoulder. So I don't think it's the same thing. And, you know, where you think your heart is like completely in the place where it's not. So it's about being like, so where does it hurt? You know, what emotion are you feeling that seems overwhelming? So, you know, what's your biggest symptom? Actually, I can't sleep at night. Let's start with that. You know, or my knee hurts dreadfully, or I'm really sad. or my mother just died of dementia. So whatever it is that actually is the thing that's upset you, or the symptom that you feel, that would be super helpful. And the other thing that's helpful is people writing down their symptoms. I mean, I know there are some issues sometimes about people coming with a list of things, and I completely understand why people do, because they've had to wait so long to see their doctor, and also it just seems they can give them focus. But actually, ideally, you would come and see me every time for each single thing, because then I've got enough time to sort things out if I can, or to examine you and do it all properly. But actually, if you wrote down all of your symptoms that you have for that problem, that'd be super helpful. I'm just going to let my cat in because she's about to go mad.
Let the cat in. We love an animal joining.
She's exhausting. She's exhausting. She's called Jones, named after Grace Jones and Indiana Jones.
Oh, really?
Yeah.
Hello to Jones.
Well, she's had enough. She's going now. Yeah, there we go. Perfect. She's gone.
And she's off. Sorry. Marvelous. Yeah. So, Anand, one of the questions. So basically, I went to the group, which is a group of around 17,500 women, who sort of our average ages are sort of 40 plus. So many who've been in long-term relationships, some who are in new relationships, but many who've been in long-term. And when I asked them what they would like me to ask you, one of the key things was, what symptoms and signs should I be looking out for as far as my partner's health is concerned as we get older? So kind of 40 plus. So what are the most, first of all, I should probably ask you, what are the most kind of common health concerns for men as they age? And secondly, both for those men and for their partners, what are the key signs and symptoms that we should be looking out for?
So that's quite a big question.
Yep.
So I'm kind of going to focus it, but if I focus it around, for example, the top causes of death, for example.
Yeah.
So causes like, I think 1 and 5 are a mixture of cardiovascular disease and cerebrovascular disease, which is strokes. So heart attacks and strokes. Also in the top 5, you have lung cancer. So if we just start with those, just because they're quite big diseases, and then we can get onto the things like prostate problems and erectile problems, which also occur, but are not necessarily as high. I mean, prostate drops in and out of the top 5, depending on where you are and what country you're in. But certainly it's a significant factor too. But lung cancer, for example, is really common, but 95% of people who have lung cancer were smokers. So either current smokers or were smokers. So that's certainly something. If you have anyone in your family who is a smoker and they develop a cough that lasts for more than 2 or 3 weeks, no matter how well they seem, I would like to see that person, because I'd normally listen to their chest, examine them a little bit, and probably send them for a chest x-ray. In some areas in the future, they might consider doing CT scans, because they're a little bit more, they're much more likely to pick up illness. But again, scans are only as good as the person operating it and the person looking at it, because they cut at certain intervals. So it depends how thinly they're cutting. So if you're cutting it every centimetre, if that cancer is smaller than a centimetre, you won't pick it up. So that's part of the issue where some people get very frustrated that doctors didn't pick up their illness. It's just because sometimes it doesn't show up on the investigation that we choose. And at the moment, for lung cancer, it's a chest x-ray. If someone's got a persistent cough, if they're coughing up blood, we absolutely want to see them. If they're short of breath, of course we want to see them. And that's more difficult in this COVID environment, because if you've got a cough for a little while, you're sent for a COVID test, you're advised not to go to the GPs. So if you have a persistent cough for more than 2 weeks, I do want to know about it anyway. So please come and contact us. Don't just assume it's COVID, particularly if you're a smoker. Okay. That's part 1, I'd say. Then ischemic heart disease. I mean, how do men know? I mean, if they've got chest pain, central, like a weight on their chest, doesn't have to be like an elephant, because that's how they classically describe it. But if you do feel like a weight on your chest after a particular distance of walking, and then you stop and it goes away again, and it keeps happening like that, that's definitely something I'd be concerned of. Feeling shortness of breath as well at certain distances. That suggests that actually, as you get that distance, your heart's not receiving enough oxygen, and therefore it's telling you to stop. and then then the heart settles down, and then it can get more oxygen in, so it doesn't cause pain. You've got to think of the heart like a muscle, because it is a muscle.
Yeah.
And so when you overexercise your biceps, for example, unlike me, for example, your biceps start to hurt, and as that, so does your heart. But because your heart's nerve supply is across the entire chest, it will give you a sort of crushing sensation across there rather than a specific one. Interestingly, I mean, this is not always, but generally, if someone has one single point they can touch, it most often isn't your heart. Particularly if it's sharp pain, it's less likely. But again, please always get chest pains checked out. I definitely recommend that. So that covers for chest pain. The other thing is erectile problems, actually, because weirdly, because you're I mean, one of my colleagues calls the penis the barometer of men's health, because it doesn't work when you're sad. I've heard you talk
about this.
Yeah, I know, I say it all the time, but it's nabbed from someone else. The idea being that actually, if you're sad or unhappy, your penis doesn't generally work very well. If your heart or your blood pressure isn't working very well, your erection doesn't work. It's very important the erection has both good blood supply and good nerve supply. So things like diabetes, which damage both, are very problematic for your erections. So if someone finds that they're moving from a state where they regularly had erections and they're satisfactory and they don't have to worry about them, to being kind of irregular, you can't really guarantee you'll be able to keep it or it won't last until orgasm, please come and see us. The blood vessels to the penis are only 1 to 2 millimeters in diameter. The ones to your heart are 3 to 5 millimeters. Right. So actually, it's an early warning system. If you've got erectile problems, you can have 50% flaring up of those tiny arteries and virtually none in your heart. So it's going to let me know that actually, potentially, we need to keep an eye on you. It might be, and it's now been introduced, erectile dysfunction, as one of the indicators for assessing a man's heart attack risk, in what's called Q-risk-3, which is an indicator, as a risk calculator that doctors are using in general practice now. So don't take it askance if someone asks you that. That's purely one of the questions that we're primed to ask now. If you're having erectile problems, please let your doctor know. It could be a sign of early neurological or cardiovascular disease.
And I don't know if you know these figures, Anand, it's really probably an unfair question, but how much of sort of those potentially life-threatening issues are being missed by people simply going to the chemist and buying things like Viagra? Good question. I have no idea, because obviously a lot of the time people self-medicate for years. Yeah. They were buying sort of Camagra or lots of other versions online, and now they're being able to access Viagra Connect, which is a very good drug and actually generally very safe. The biggest issue for me is the fact that people aren't necessarily coming for their heart assessment. And because they're not coming for that heart assessment, I don't know what their cholesterol is. I don't know that actually asking that question, that actually, whilst they can have sex, they can't quite do the exercise level they did before. And so those things that might trigger a question in me don't necessarily get filled out when you're filling in a form online. And also the side effect issues, but not necessarily the side effects, the possible reactions that Viagra can have with other medications, for example. You certainly can't use it if you're using a GTN spray if you've got angina, because both make you potentially collapse when you're taken together. So not ideal for that. So somebody'd asked, are there regular tests and checkups that a man should have in the same way that women will have either their breast screening or their cervical smear, etc.? Are there regular tests for men too?
Not really so much. I mean, screening is hopefully done in people who don't have any symptoms to try and find early signs of a cancer or some other condition. And actually, there's not actually that much that one can detect relatively early in men. Your prostate is like your nose and your ears, and it grows throughout life. It starts the size of a walnut and increases the size of a cantaloupe melon in some people. And so the situation that most men, for example, in prostate cancer would notice, or even just benign prostate enlargement, is that if you imagine something that has grown that much bigger and there's a tube running through the middle of it, well, that tube will probably get squeezed or kinked. And so they might notice the fact that actually their stream is a bit slower. Or the fact they have to get up a couple of times in the night because the tube gets slightly kinked within that prostate, so they don't empty their bladder fully, or they get a bit of a wet patch after they've gone for a week, so they've got a bit of a dribble afterwards, or it's difficult to start having a week. So if these things are new to you, then actually we definitely want to know about them. And unfortunately, having them doesn't mean you've got cancer, because it just means benign prostate enlargement happens at the same age group as cancer. So we want to know about that. But at the moment, PSA isn't a very good screening tool for cancer, because if you do a PSA test, it may miss some cancers. So, because it may still be normal, and actually you have a cancer there. So we often recommend that if you're concerned about it, particularly if you've got a family history, but I mean, it sounds big, but a family history of prostate cancer, say in your dad, increases your risk of having prostate cancer by 2. So, it does go up, but that still isn't a very large number, as in the total number. So whilst it might seem like a huge number increase, it's actually the total number, it's not very high. And so your total risk, it's not necessarily benefiting you to have a PSA. So again, it's on symptoms, which is more difficult. I mean, certainly whenever you're joining a new practice, they'll often offer you a new patient health check. And certainly when people get to their 40s, they get offered often a cholesterol check, blood pressure, and a diabetes check, an HbA1c. I think they're really important to get done, because having a high cholesterol at 40 is important, because if you can reduce that even by a small amount through the rest of your life for the next 30 years, it will reduce the risk of a heart attack or stroke. I mean, none of these things are you're going to stop it, because one unfortunately has to pass away of something. But it does mean that the risk gets lower and lower. So it's really important to know about this early, and particularly the impact of, by 2030, for example, diabetes is going to cost the country £30 billion alone. So it's a huge part. It's like that will be a quarter of the entire NHS budget, just on treating diabetes and its complications. So we really want to see these things early. And I think what you hopefully will see more and more is more evidence-based screening come in. So where there actually is a real benefit across a population of us doing a test, like they're moving from, the poo testing. We're both too young for this, but there's the poo testing that sort of the over 60s have to do just to make sure there's no blood in their stool. They're going to change that in lots of areas to a single tube test up your bottom in your 50s. And if that's by a little camera test up your bottom, and if that's negative in your 50s, it's unlikely you'll ever develop cancer. So they change all the time. So what I'm saying now isn't set in stone. They may well next year come out with a whole raft of screening tools, but at the moment for men, it's more on what your symptoms are and taking advantage of a health check if you get offered it. But also, if you have a family condition, particularly if you've had a first-degree relative die before the age of 55, of heart disease, for example, you would definitely want to tell your doctor about that, because that increases your personal risk.
So you mentioned at the beginning, Anand, about the Centre for Men's Health. So could you tell us a little bit about what it does? Because I really want to talk about men's hormones and testosterone, and I know that's part of what it does.
I think initially that is the big component of what they were initially set up to cover, because the founders of Professor Malcolm Carruthers, that was his sort of passion. But as we sort of moved on, we've kind of evolved into increasing what our remit is, and we cover quite a lot of sexual function issues. So yes, we cover testosterone and testosterone deficiency, but we also cover erectile dysfunction, premature ejaculation, delayed ejaculation, all of these conditions that are concerning to men. I mean, 25% of men will complain of a sexual dysfunction, particularly premature ejaculation.
You're a mind reader. You are a mind reader. That's the next question. Well done.
So premature ejaculation is really quite common. Everyone thinks it's going to be in young people, but it's not. It's quite spread across the population. They do think there's some sort of evolutionary importance to it, because it means you would ejaculate and get your genes across as quickly as possible. So you weren't going to be hamstrung by the saber-toothed tiger that was chasing you before you got your end away. So it's important that it's kept in the population because of those reasons. Now, but these days, unfortunately, people are not necessarily told to be so enamoured of men that ejaculate early. But it's, generally what we've been hearing is that premature ejaculators make great lovers, because they tend to focus on the other partner to achieve their pleasure before they penetrate or whatever. So so it's quite common. I mean, erectile dysfunction up to 40% of 40-year-olds, 70% of 70-year-olds. So it's really common, and the younger end are more likely to have psychological concerns. But some have physical, and at the top end more likely to have physical concerns. But but they're both interlinked, as I'm sure you know.
Absolutely. So, well. So can we talk, Anand, about what happens to male hormones. Oh, no, I'm not going to call them male hormones. Hormones in men. Can we talk about hormones in men,
absolutely.
specifically testosterone, as men age? What's all going on? Because, you know, obviously we talk an awful lot about female hormones, but what's all going on?
So as men get older, their testosterone does slowly decline. And it's not by a huge amount, it's perhaps by 1% a year over the age of 40.
Yeah.
However, for a certain proportion of men, that decline becomes symptomatic. Now, probably there's lots of studies, and the problem with studies is just a whole load of statistics. You're like, well, which one do I believe? I mean, you have the very, very large scale studies to find out these things about what's true. I mean, so much happened with the menopause situation, for example, when they did that massive, was it the Massachusetts?
WHI.
That was, exactly, that's the one. Women's Health Initiative, wasn't it? And that scared everyone. From prescribing menopausal hormones for such a long time. Yep. So we have to take these things with a pinch of salt, but also if lots of studies are telling us the same thing, let's say between 20 and 40% of men over the age of 45 to 50 will have a low testosterone. Okay. And it's much more significant if you have type 2 diabetes. And if, for example, you're overweight. I mean, unfortunately, up to a third of London men can't see past their belly to see their willies. And that increases your risk of a third.
Wow.
Yeah, because your belly doesn't actually have to be that big. I'm talking about flaccid, not erect. But actually, that sort of belly diameter of that amount of fat, unfortunately, because that fat unfortunately causes problems with your sugar control, that leads you towards diabetes. It also increases your estrogen. It breaks down your testosterone into estrogen. So testosterone is less effective. You get higher levels of estrogen, so your libido starts to play silly beggars. And also you might get sort of gynecomastia or breast tissue development as well. And also the extra chemicals produced from the fat mass are carcinogenic and also can damage your heart and blood vessels. So it's really important that we, I would say this is not, a fattist in any way, but actually it's hugely important for us if we can, to actually be able to minimize our waist circumference, because that is linked to a much lower incidence of low testosterone, lower diabetes, being obese is linked to 22 different cancers. So it's so important. So so it's a long answer to a short question. Your testosterone falls, as I said, sort of 20 to 40% have a low testosterone, but most of those won't be symptomatic. Most of those will be absolutely fine and not really notice.
Right.
But somewhere between 2 and 12% of men will both have a low testosterone and be symptomatic.
Right.
And the two together is testosterone deficiency syndrome, or what some people call andropause.
Yes.
But because andropause can happen at any age, it's not like a specific time. We've got some 25-year-olds have got to that level already. And you might get an 80-year-old whose testosterone's fine.
Yeah.
They're still sexually active, they've never had a problem. It's not, for example, women who almost all, I'm obviously talking about people with uteruses, etc. All of these people will get to the menopause. That will happen, and I'm afraid it's not an all event in men. So it's that's why when we have these conversations, that's what's really helpful to have this time, is to try and work out all those different conditions that can either mask testosterone deficiency issues, or they can mimic it. And so it's like, well, you could have a thyroid problem, or you could be actually depressed, or it could be all of these things put together actually. And treating with testosterone doesn't cure everything, but it often does give you a much better response to the other treatments. So for example, there's some evidence that, a depressed person, yes, they may get better on their sertraline or whatever drug that they use, but they're more likely to get better if you replace their testosterone to a normal level. Yeah. Diabetics are literally less likely to die. There's a study going to be coming up soon that if you treat them to a normal testosterone, they're literally less likely to die over several years. So I think that's so super important.
Wow.
But actually, we don't ignore this and don't just think, oh, it's just men getting older, or it's just a failure of my masculinity, and actually, so I don't want to talk about it. And there are so many symptoms men complain of, because it's not just, the main two are erections not working particularly well, or the second one is that they lose their libido, so their sexual interest goes. But there are lots of others, like sort of a sense of brain fog, just feeling that focus at work going. And often we have patients coming in that actually they really, they're on their last warning at work, or they've lost their job because of it, or they just, they've not had they might have been very ambitious, and that seems to have gone. physical things can happen, and their middle gets a bit wider, and it's a bit of a vicious circle. Because is that because of the poor sugar control? Is that your diet, or is it the testosterone dysfunction? Your bones can become a bit weaker, your muscles are weaker. You know, often we get people saying, yeah, also the people we see tend to be quite driven or have been very driven, and they like going to the gym, and lots of young people do these days, but they find, I go to the gym loads, but I never put on any muscle, or it's really hard for me to do so. So, you know, ideally we check all of these people to see what's going on. And you know, I'm certainly not saying that everyone should be having testosterone. You know, you need to be given it in a safe environment and monitored, and there's lots of monitoring to be done. It's not, but it's something that is so important to men's physical function. I mean, it really primes the sexual system. It really sort of helps brain function in men, and it's really important for sort of muscle and bone strength. And actually, you know, we've got so many people who have fractures, or, you know, as a result of falls in later life, you know, and having that ability to, you know, or potentially to reduce that fracture risk is really important.
So, Anand, how would you, you know, kind of, would you be blood testing for somebody who's, you know, coming to you talking about this symptomology? Would you be looking at blood tests to see what their testosterone levels are like? And then what would be the way forward?
So first, I'd suggest that they just fill in there's a questionnaire on the Centre for Men's website, and they can just fill that in to get a vague sort of score about whether they're more likely to be testosterone deficient or not. And it's a lot of parameters like we've talked about: physical symptoms, brain symptoms, you know, general health, etc. And then, you know, we'd have a chat to make sure it's not more likely to be your thyroid or something else. But we would also do blood tests, as you suggest, and particularly we do your testosterone, and we generally do that within 3 hours of waking, because your testosterone's at its highest in the morning. Or if you're a shift worker, within 3 hours of waking, and then it tends to decline. So it's important to get a good level. And we'd also check you for diabetes because of the connection. We check your heart health. You know, we want to do a whole host of blood tests, including your iron studies, because condition like hemochromatosis, which is an iron disorder, and liver disorder, can mimic some of these symptoms. I'm afraid it's quite a range series of tests that you have to do for it, because so many you know, conditions overlap. But if you, for example, define someone's right, your blood tests suggest that they are low, that your levels are low, and you have these symptoms, you may be offered, with your consent, a trial of treatment. Because, you know, you might have a low testosterone and you might have these symptoms, but we give you the medication, it doesn't make any difference. There would be no point in carrying it on. The symptoms, you know, in these cases where actually people are generally relatively well, there's no great indication. There might be in the future because of the studies that are coming out with diabetics, that actually you would consider treating them preemptively, but that's not where we are at the moment.
Okay.
But yeah, the treatment is either gels or injection. Generally in the UK, tablets have fallen out of vogue because you have to take them with a slug of olive oil, so they're not really very palatable. No, exactly. But yeah, people, you know, they deal very well with it, and you know, they get used to rubbing a little squeeze of gel on their shoulder, just like women who are using estrogel or those treatments, get used to doing that on a daily basis. They get used to not spreading it on their partner and things like that. Yeah,
I mean, it's so interesting hearing you speak about it, because about 8 years ago, I had my ovaries removed, so I went straight into surgical menopause, and for me, having estrogen back made an enormous difference, because the biggest effects for me were psychological rather than physical. But it kind of felt like a piece of the jigsaw was missing until my testosterone was replaced, because the things that I was noticing was, you know, kind of, I used to be a really confident driver and my confidence had gone. I didn't seem as sharp cognitively as I had done before. I was always a very up, bouncy person, and I'd kind of lost my bounce. And then I saw somebody who said, well, clearly you need your testosterone back. And just I mean, obviously it's a, you know, it's a very tiny dose for a female, but just having this tiny dose of testosterone back, you know, a pea-sized blob every day, was just like, oh, okay, now I get it.
They are so important, and yeah, I think I'm sure you, because of the work that you do with menopause, recognise just how sort of badly sometimes women are treated in terms of not getting access to the hormones, and or if you do get hormones, they don't necessarily suit you, and therefore there's a reluctance to move you to another combination, or there's not necessarily an understanding of the different types, or the new versions available, or even using testosterone. People might be happy with using the traditional mixtures, but not using that. And then the difference comes in men, because actually you should be man enough to do without it.
Yeah.
And you should just be getting on with your life. And if you are failing to do those things or having to have additional therapy, then there is a weakness around that.
Yeah.
So there was some fabulous work. That was this particularly brilliant book by Kate Lister called The Curious History of Sex, where she talks about men in the 1800s and 1900s, very sort of well-renowned doctors, sort of removing gonads from monkeys and either stitching them into humans or squeezing them for the extract and injecting them as part of sort of hormonal treatment in the 1800s. Yeah, it's incredible. I mean, it's absolutely fascinating. Her book is wonderful.
Wow.
Dissect all of that. But the way that men have been treated, and in her book, she talks about how women have been treated as well. And the Kellogg's burning of the clitoris to try and reduce sexual. It was just all dreadful. But yeah, it's fascinating that men have to prove that they've got low testosterone. However, you can give a woman hormones without actually having any blood levels, because perimenopausal women could potentially have treatment, etc.
Yeah, absolutely.
And you have to prove it by having a high LH or FSH, if that makes sense. And in fact, the guidelines suggest you don't bother doing the tests, because
the guidelines do indeed suggest that. Unfortunately, not everybody's read them.
No. I get to do both sexes in my GP practice, which I find really enjoyable, because it's really nice to be able to use a bit of knowledge from either side. But it's the combination, isn't it? And I love the fact that the estrogen testosterone interplay, and how men actually desperately need that estrogen for their bone strength and all this kind of stuff.
Absolutely. So as I said, for me personally, I had to seek private help to get my testosterone, because we won't go into that long story. But so today, obviously, on the NHS, we only have unlicensed testosterone products for women, because obviously they're only licensed for men. So for women, we come up against an awful lot of hurdles for women who need testosterone to be prescribed, even if they're women in surgical menopause. How challenging is it for men who potentially need testosterone replacement to access that via the NHS?
So I'm not here to NHS bash at all. I am incredibly proud of the NHS and what it means. Just if we look at our education, for example, so at medical school,
that's the thing.
I learned about testosterone because your gonads produce it.
Yeah,
testicles produce it, but I didn't learn about any treatment for it. I learned about the types of failure, but not what you do with people otherwise. Yeah. I didn't really learn about erectile function at all. And so all of this I only learned after becoming a GP.
Specialism, yeah.
I'd specialised, and even then I hadn't learnt about it. It's only when I became a trainer of doctors that actually we set up a psychosexual residential where we would discuss, well, what happens if someone comes with premature ejaculation or erectile problems or whatever. I was like, why don't I know about this? Which is why I went on to do my study at the European Society of Sexual Medicine, which is just amazing, and and got my letters and things out there. But it was just fabulous to learn about something we don't get to understand. Now, if I look after, for example, in my practice, we've got 8,000 patients.
Right.
So I am the doctor for that number of patients. There will be only a very small number of people that will actually, one, ever come into contact with me because there's 4 other doctors.
Yes.
But also will come to see me with there's only 2 to 12% of men with TDS. So of that 8,000, 4,000 perhaps are men. Of those, maybe only like 50 will come and see me. Mm-hmm. So, actually, it's a huge, it's a very small number of people that might ever come see me with that conversation that actually makes me test their testosterone. Mm-hmm. So, and also the levels that we have in NHS practice are dependent on the lab readings.
Yes.
And your laboratory normal levels start at often 6 or 7. which is significantly lower than what I believe to be, and what, you know, the British Society of Sexual Medicine, European Society of Sexual Medicine, the International Society would suggest is a low testosterone level.
Yeah.
So you get lots of people saying, oh, well, this says normal, so you're fine.
Yeah.
But because they haven't been educated, and not because they're not willing, but just because
no, they just haven't had the education. It's the same with menopause. You know,
yes.
we're in, and that's why I wanted to know, because it kind of seems to me as though, obviously, my focus has very much been on menopause, but I kind of, having looked you up, having read a bit about you, I kind of feel like we need another sort of education piece around this for men too, more widely, for the general public, but also for our healthcare practitioners.
And I think that's what we're trying to do. And I'm a member of a group called the Primary Care Testosterone Advisory Group. And what we try and do is have training days about men's health, but particularly we generally always have a segment on testosterone, because it's something that isn't talked about very often. And certainly I was very kindly offered to curate a RCGP conference on men's health. And I was very specifically wanted to put in testosterone, because we would then be capturing 100 to 150 doctors we otherwise would never reach. So it's really important for us to carry on that conversation, and we try and make sure that all of the trainees are, as many as we can, are invited to the British Society of Sexual Medicine yearly conferences, and they get to attend for free, so that we can educate them about this. So yeah, I mean, just as menopause should be on every training scheme, so should, you know, testosterone issues. Yeah,
absolutely. So a few sort of direct questions for you, lovely, if you don't mind.
No, of course, fine.
There are three specifically that I wanted to pick out. One was around a lady whose husband is getting, and I realise that you can't give individual advice, it's very generalised. Yeah. One from a woman whose husband is experiencing mood changes, sleepless nights and hot flushes, and he's not on medication for anything.
So, I mean, so if I heard that history, I would recommend that, well, as a doctor, if I heard that history, I would suggest we do some blood tests.
Yeah.
We'd examine first and then we do some blood tests.
Yeah.
I certainly would suggest that that person go and seek medical care. Now, all of those symptoms you described could be testosterone deficiency. If, however, someone is having night sweats with weight loss, that's much more that's a much more concerning condition.
Yes.
Or situation. So I definitely want to see these patients to discuss what our next steps are.
Okay.
This is not to worry you, but it's just there are certain things that flag up concerns in our heads.
Yeah,
but certainly what he says, it more leads me towards a hormonal condition, or you know, for example, thyroid could be doing that to him. It could be testosterone, very much so. But also if there's the added night sweats and weight loss, that's more concerning. Please get to the GP.
Okay. Second one is, this is from a concerned woman who says that her husband used to be light-hearted, fun and enthusiastic. He's now tired, experiencing joint pain and irritable. He's been to see the doctor, and the doctor has told him that it's just part of getting old.
Oh dear. So it can be part of getting old, but not everyone turns into Victor Meldrew when they get older. So I would certainly suggest having a thyroid, a blood count checked. You know, you can be listless and miserable because you're anemic. You know, you can be tired because your thyroid's not working. But again, those are the same symptoms that you could get in testosterone deficiency. I'm not trying to say testosterone deficiency for everyone.
No.
It's just that actually, you know, these are symptoms that could have a physiological basis. They could also have a psychological basis. You know, actually, as men get older, you know, I don't know about your reader or your connection there, but that person could have a significant psychological or social issues going on in the background that cause psychosomatic symptoms.
Of course.
And it's important not to lose the fact that actually, if they're happening in your head, they are still real. You know, you are still feeling them.
Absolutely.
And your brain is as much part of your nervous system as your hand is. So, I would potentially just go and say, look, is there anything else that could cause my symptoms? Mm-hmm. And if you're not sure about the response you're getting from your doctor, there are other doctors in your practice usually. You know, there are very few, I mean, you know, lots of single-handed doctors are fantastic, but there are very few practices that are now single-handed in,
yes,
in the
of
country.
course. Yeah.
So actually there'll be someone else in the practice you could potentially talk to that you can have a second opinion for. I mean, you know, it may actually be absolutely right. It may, you know, what you described, because of the times you've been seen before and because of the blood tests you've had before, that actually is potentially something what the diagnosis.
Yep.
But you know, I don't think necessarily old age is a diagnosis.
No, exactly. So this could potentially be something that you might be able to help with. This particular woman says that her husband is experiencing sexual issues. He's experiencing difficulties, but he just,
So is this erectile difficulties?
Erectile problems, yeah. But whilst she has tried to talk to him about it, he just won't talk about it. So I think your advice is probably for her rather than for him.
Yeah, absolutely. It's really tough engaging your partner in healthcare sometimes, because you don't want to be the one nagging them.
Yeah.
And also you don't want to have to keep telling them. I mean, because I'm sure that may not be the only thing that's happening in his life, and he may be behaving in other ways that aren't particularly helpful as well. Yeah. And that can't necessarily be helping the relationship. You know, for him, if he's not sexually performing, and again, for men, often it's about being a performance and yes. being, it's visually showing that you're erect. Yeah. And what that means, he might be hideously embarrassed that actually his wife is worried that he doesn't fancy her anymore, mm-hmm. or something like that. I mean, my concern is initially always the physical. Has he got some underlying cardiovascular problems? Yeah. Is his heart not pumping as well as the narrowing of the blood vessels? But also, once you get erectile issues, you sort of learn funny behaviours around that. Mm-hmm. In your job, I'm sure you see lots of people who have learned behaviours around their condition.
Yeah, absolutely.
So often men who have erectile difficulties become premature ejaculators because they're trying to use whatever erection they've got for as quickly as they can. Yeah. So actually, you have to treat their erectile problem, not their premature ejaculation. So I would perhaps. I mean, there is something, the Sexual Advice Association has a fantastic app called the Smart SA app. Right. Now, it's free to download. It's a charity that's supported by some very esteemed colleagues of mine, who even I would go to for advice. They're very capable and lovely and knowledgeable, and everything is evidence-based. And you can download the app and you can fill it in both for yourself, but also for your partner. So you can assess their sexual issue.
Oh, okay, that's really useful.
Yeah, it's really useful. And then it will give you an idea of what that might be. And then it will highlight one of their fact sheets, which will then give you some information about the background condition and also what you can do about it. Mm. So it might be that if she decides to arm herself with some information, she perhaps then, God, it's sometimes difficult, isn't it? Because, if I gave you a leaflet on erectile problems, how are you going to take that? Is that going to be a slap to your face? I think taking it away from the sexual arena, I think making sure you're not having this conversation whilst naked, yep, and in bed would always be something I would recommend. It's difficult to choose when to have a health conversation with someone, but definitely not an arena where their issue might be considered more of a jab at them.
Yeah, and it sort of goes back to what we said originally, isn't it? We still, as a society, sex is very much something we do, not something we talk about. We don't talk about what is pleasurable. We just crack on with it. And do we ever Absolutely. Really know? Have we ever really got to that point where we know where our partner knows what's pleasurable for us and vice versa? There does seem to still be. Go on.
Yeah, so I was just thinking about something similar to what you were saying. For example, you've been sharing so much that as your estrogen falls, your skin sensitivity changes. Yeah. So actually, if your husband has been, or whoever, has been basically stroking the back of your hand for years because that always gets you going, or the inside of your wrist, or whatever it is that sexually excites you, and you now think, get the hell off me, how do you share that with him? How do you talk about these things? Yeah. It's ridiculous that we have got such a we've developed in a way that sex is expected, and sex is talked about everywhere except between the people having sex, isn't
Absolutely.
it? You see it on Hollywood, you see it in magazines like Cosmopolitan or Moore's Position of the Week or whatever it was.
Yeah.
We're indoctrinated to it, but we're also indoctrinated that we have to be this very buttoned up Victorian people. Yeah. And so now you've got this sort of very sort of Victorian affect meeting pornography. And how do you have a conversation that allows them to be sort of married, or indeed strip away the excess of both and kind of go, shall we just have a chat about the way you kiss?
Yeah.
Or can we have a little conversation about, and I appreciate you probably wouldn't word it in that way. You might want to suggest, I've read this, or I've heard about this. Would you mind if we try that? And obviously, you know far more than I do about what are these like psychotherapeutic interventions. I'm probably making a hash of what you've been doing much more professionally.
Not at all.
But, I've got 10 minutes, so it's kind of like, right, blood test, go, and then come back. And it's often in the series of conversations that I get more out of men. And it's helpful to have that series, because by the third or fourth time, they sort of plonk themselves down and go, didn't work. Knob did nothing. And you're like, fine, be honest with me. Use the words that feel comfortable to you. And we can actually get to the point really quickly and then move on. But also, once you've had 3 or 4 conversations with someone, it's just so much easier to kind of open that door again about emotions and social stuff. And sometimes that door does get slammed back in your face. And you're like, okay, I generally really do think this is about your workplace, but you don't want to go there.
But you don't want to hear that.
And I think if this lady's partner doesn't want to hear that, then nothing that she tries is going to get there until, unfortunately, probably something happens. And it might have to happen to a friend or a family member, or it might unfortunately happen to himself. That's what we really struggle with. The reality of trying to get people we love to listen is that often they don't.
Yeah, absolutely. I can't tell you how appreciative I am of your time.
Not at all.
It's, there's so much more that I want to ask you, but I recognise that you have an evening to go away and enjoy, and a cat who needs your attention.
She's scratching away.
So, Anand, maybe, you don't have to agree to this, but maybe in the future I could ask you back again, and we could talk some more. And I'm just going to throw this at you, and I haven't primed you at all, but just bearing in mind that this has very much been focused on men's health. And as I said right at the beginning, this is the last day, and we're coming to the last few hours of Men's Mental Health Month. Could I ask you, and I realise as I say that I'm throwing this at you, for anybody, and I'm particularly kind of focusing this on men, if there is a man watching this, and there is any part of him that has thought, do you know what, actually, I think I am in trouble, I think I do need to do something, what would be your kind of top 3 pieces of advice, or your top 3 tips? Could be signposting, could be things to do. What would they be?
I'd say speak to someone. And that doesn't necessarily have to be your GP, but I'd like it to be if you can. Because sharing that bit of sadness or pain or whatever it is that's causing you difficulty, please tell someone. Because it makes a massive difference to your mental health, not just keeping it all inside and fearful and worried. Second thing, tell someone else. It is actually, sharing that information with as many people as you can is often so unburdening. Don't be ashamed for whatever condition it is, particularly if it's mental health. You are not alone. You are not a failure. A third to a half of people will have a mental health condition in their lifetime. So it was, to be honest, it was just your time. And we're not given the tools to deal with this when we're younger. So it's not surprising that we wouldn't necessarily develop them when we're older. So I'm afraid this was just your time. And finally, I would say, particularly in terms of mental health, almost all the time, it gets better. The deep sadness you have, the despair, the hate you may have for yourself or the situation that you're in. And I'm a doctor, so I never say 100% or always, because that's never true for everything. But the majority of people, they do get better and they live, happier lives. So please do persist.
I would absolutely echo that. One of the things that I say regularly is we all have mental health. Some days it's better than others. It depends on what's happening in your life, but whatever you do, you know, don't be afraid to reach out, because somewhere there is somebody. And as Anand says, whether it's your doctor, whether it's your partner, whether it's a friend, you know, it's not a weakness. And actually reaching out is the strength. That's the moment where you can actually change things. Anand, bless you. Thank you so much. I'm so thankful.
Thank you so much for having me on.
And I will be sharing this, so we'll definitely be tagging you in it. And I very much look forward to speaking to you again in the future. Enjoy your new home, and
thank you so much, Sam.
Thanks so much.
Have a good evening.
You too.
Bye.
Thanks. Bye bye.